We are with you, and we're learning.
Hello, Don.
Yes, we're learning about your patient right now from Claudia.
Yeah, and the next patient is a 7-7 female patient, and her diagnosis is a relapsing vitreous hemorrhage in choroidal melanoma, already treated by proton beam radiotherapy. Parameters of the melanoma, so the apex height of 8.3 millimeters, max base diameter 15.8 millimeter. So the surgical plan of today is doing an endoresection of uveal melanoma.
So this is challenging. Mario, tell us,
Yeah.
how did you decide that this melanoma needed to be removed?
This is a patient been treated already with the proton beam radiotherapy. The tumor is not active anymore. But because of the risk factor, this is the posterior location, the size, and also the diabetic retinopathy, the vasculopathy induced is a toxic tumor syndrome.
Mario, when was the proton beam therapy performed?
Was done in August. So we have now a protocol according to the data also published that we try to do, let's say, as soon as possible. Also prophylactic. We are not waiting when the exudation is too big because it's a collar stud. This is like a mushroom here going to the Brooks membrane that are inducing like a congestion of the vessel right here. Doing now what probably we cannot do later if the bleeding is so much, okay? So we are doing the laser all around. So we are preparing, let's say, our field.
I think I only do the laser around the excision of the retina.
Okay, so if you also ask to the oncologists, they are very pleased if you can do at this time, because then otherwise the risk factor to have neovascular glaucoma still is high. So
or intraoperative angiography may be a good option maybe for this case.
Yeah, we do it, but the problem, you need to see the patient longitudinally. It's not a matter of this time, but because the tumor is there, so we'll increase this, let's say, vasculopathy over time.
So this would be a good time to reveal to the world that this is a family business, that you actually know are related to the person who treated this tumor. And that's, of course, the wonderful Martina Angi, and highly skilled. Martina, would you be able to make a comment about this protocol of endoresection following proton beam and your thoughts?
Yes, hi Don, thank you very much. We had a systematic review last year, and by examining the case series published mainly from Antonia Houston, Becky Rakis, and the Liverpool experience, prophylactic endoresection in tumors which are high thickness higher than 8 millimeter, it's useful to prevent, as Mario said, the toxic tumor syndrome. This patient in particular has a vasculopathy, and she has to be on anti-aggregant treatment, and she also has a borderline diabetes. Therefore, we do expect radiation-induced retinopathy to be worse, also because by the extent and the thickness of the tumor, the macula was irradiated and also the optic disc. So because of the expected risk of bleeding, we want to make sure there is as little as possible risk of neovascular glaucoma in the long term. And this is the reason for the laser, which is most important in the proton irradiated area, which is near the tumor, but is also helpful in the periphery when we foresee this patient won't be a good candidate for follow-up, for an easy follow-up. You know, if a patient is easy to collaborate with, we of course perform a peripheral panoramic fluorescein angiography in the long term. But in patients who also have some difficulties with cooperation, as you see, this patient has some troubles with fixation and compliance. We try to prevent having to do that in the clinic with very difficult patients to manage.
You know, Mario, you should really at this point tell people that the following images may be graphic, and if you wish to look away, just like they do in television, because this could be...
Yeah. So we will make a tunnel now. Are you ready?
We see you.
This is the retina first, okay, that we are getting. And this is the tumor. So now we try to make the hemorrhage, you know, is coming but inside the tumor. Increase the pressure to 60. So far we are managing quite well. we need to touch the base now. We are crossing the Brooks membrane.
Mario, are you going to collect any specimen for histology here?
Sure. This is the point that I was saying before. So we collect the specimen, as for endophthalmitis, we got even after the treatment, specimen because for gene, sequencing, because of course there is, regarding the monosomy 3 and class 1 and class 2 pattern, there are specific prognostic factors related, to the gene profile. So this is also an important point that we can provide to the patient to tell him the prognosis.
Well, so far it's going just totally great with no bleeding at all that we can see.
It's clear to try to clean as much as I can. A good point here. So what else I have to tell also that we closed the vortex vein from outside. And this was done when the clip was placed, okay? The clip for proton beam. So this is the routine that we do when, in the oncology center, put the clip, they close the vortex vein related to this, quadrant, okay? So this is an important point to avoid venous air embolism and other things. So it's not the problem regarding the fluid air exchange or whatever because it's closed.
Mario, a question. I mean, is it always easy to find the vortex veins? Veins are highly variable. Sometimes you have two, sometimes you have one, sometimes branches.
Yeah,
Are there any problems making sure you've got it all?
So the vortex vein, as you were telling me, were between 4 and 7 and between 14 millimeters and 25. So we look exactly, all the quadrant around if are, in that quadrant. If there is more than one, we close all of them.
Mario, we're joining you again.
Done. So we have done. What I want to tell you, how I did the exchange, okay? So basically, I was not using perfluorocarbon liquid at all. And I was, because you know that also the octane has a high vapor pressure, so we cannot use anymore. The caline we can, but I didn't use, and I didn't use air. So how did the exchange? Just with the chandelier, infusion of silicone oil, and with the other hand, I was removing the BSS. So the oil was going from up, I was removing BSS from the coloboma, and now, the retina is flat. Of course, we will have some bleeding here, okay? That's in 100% of the cases, but the day after, in the few days after, all this part that is on the retina will be reabsorbed. And, the laser around is done because I did previously. So that's why you see here now, the laser is already done. And I know that if I don't do before, I have the blood on, and I cannot do any more, in this way.
So you're basically done at this point. Obviously a very unusual case. You had answers for every question we could ask, and if you didn't have answers, Martina had even better answers for every question. So any thoughts? It went perfectly, I think.
Yeah.
Mario, you said that you have already closed the vortex veins like 4 months before. So do you think it may form some collaterals during this time, so that still you have the risk of air embolism?
I think that we can make other vein connection, you mean? So I mean, probably can be, I'm not sure, I told you that probably in some we have more than one in that quadrant. We explore all of the quadrant, but still, I mean, we try to stay on the safe side. So it means it is not the only that step that makes everything, So we are not going through the air, and still we try to use decaline instead of octane. All these things are the one that we know to avoid, venous embolism, and we'll try to do all of them.